Thank you so much, everyone, for attending our Innovative Discovery Series. This is the first Innovative Discovery Series, so we are very excited to resume our series. And we are even more excited to have Dr. Saloner from Johns Hopkins today to give us a talk on medication for opioid addiction behind bars. But before I introduce him, let me mention some housekeeping issues. So as before, as last year, we will continue extending CME credits for our tech talks and our ID series presentations. We will distribute the information via email to those that registered for today's event, but if you did not register prior to today's talk, you can still obtain CME code information from Lisa Maturo at Christiana Care, and I'll put her email in the chat box in a few minutes. Our March 26th ID series, we will have Dr. Stephanie Dutch from Nemours Health System, who will talk about balancing cost against the price of missing child physical abuse. This is obviously a very important topic, so please do not miss this ID series. And on May 6th, we will have a tech talk with our own Risa Lee from the Value Institute here. And her title is not known yet, but I'm sure she will give it soon. So we are, again, as I was saying, we are extremely excited and honored today to have Dr. Saloner. Dr. Saloner is Associate Professor in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. And moreover, in 2020, he was endowed the Bloomberg Associate Professor of American Health, a position that is supported by the Bloomberg American Health Initiative. He received a PhD from Harvard in health policy and did a postdoc and was also a Robert Wood Johnson Foundation Health and Society Scholar at University of Pennsylvania. Very relevant to us, he was a technical advisor to the government of Delaware between 2017 and 2018, and he worked with the leadership in the Department of Health and Social Services to provide recommendations to improve access and quality of treatment for individuals with opioid use disorder in Delaware. And I know that the state really benefited from this project and this report. He received multiple awards, the last one in 2019, which was the Alice Hirsch Emerging Leader Award from Academy Health. He's a PI on multiple grants from NIDA, the Department of Justice, foundations focusing on policies and access to medications for opioid use disorder. He has a very long list of peer-reviewed publications. He's a teacher and a mentor and a very sought-after speaker. So we are extremely lucky to have him today giving us a talk. So thank you again.
Well, thank you so much for that very generous introduction. I feel like after that, maybe all I can do is disappoint. So
I don't think
hopefully
so.
hopefully the talk will be okay. I'm gonna just share my screen in just a moment. So let me just get the technicals down. And while I'm doing that, what I would like to say is that I'd like to just keep this very informal. So, it's my preference that as I go along today, you just ask the questions you have, and we have a little bit of a conversation. And I don't necessarily need to get through all of these slides. It doesn't really matter to me. So if I need to hurry up, I'll let you know. But other than that, let's just chat as if we were in the same room together. Okay, let's. No, I did this just a moment ago. Let me see if I can. I'm trusting people can see the screen share okay.
Yes.
Um, okay,
Perfect.
wonderful, wonderful. Okay, well, I'm going to talk about this work that I've been doing in Delaware, but what I really want to let you know is that I'm someone who has had a long-standing interest in basically access to care for people who are underserved in our health system. And of course, you can't see our addiction crisis without kind of having that context that many people are underserved and missing chances to get effective care. And once you start thinking about that, you really see a lot of systems where people are missing opportunities to get the care that they need. And foremost among those, I would argue, is our criminal justice system, where we have just a spectacular opportunity to help people, and the consequences of not helping them are really vast. In today's presentation, I'm just going to provide a little bit of background about medications for opioid use disorder. Some of you may know a lot about this topic, but maybe some of you don't. And then I'm just going to provide some national and regional perspectives on this topic, share with you some data from Delaware, and conclude with some thoughts for next steps. Let me start with, I think, the stark data that we are seeing year in and year out on our overdose crisis in this country. These are data from the Centers for Disease Control and Prevention. What they show are drug-involved overdose deaths by type of drug. You can see that foremost among those are the opioid drugs. They contribute to about 2/3 of all overdose deaths, or at least they're identified as being involved with opioids. And the orange line is what I really want you to see. That's deaths that are linked to synthetic opioids, and most particularly the drug fentanyl. So fentanyl is very much a drug of common use in the Mid-Atlantic region. Delaware, Maryland, the District of Columbia, where I live, have all seen huge spikes in overdose deaths linked to fentanyl. Fentanyl is much more potent than heroin or prescription opioids, and so many people who have been used to using some of those other opioids, once they transition to fentanyl, just experience dramatically higher overdose risk. And indeed in some communities, in some drug markets, fentanyl is really the dominant drug that's available, and you can't really find much heroin anymore. Very sad to say that although there are many wonderful distinctions in Delaware, one point of, I think, great concern for the state has been its standing in the national overdose death rankings. It's now in second place, and that is actually higher than it was when I started working with the state a few years ago. So Delaware has very much been trending in the wrong direction in recent years. And I think this is in spite of some really important initiatives in the state. So I want to be clear that I don't lay the blame of this exclusively or even substantially, at the feet of the state. Although I think that there's a lot of areas for improvement. The reality is that fentanyl just being on the streets has become a huge problem in Delaware. Let me stop and see if there's any questions or comments, observations from your own work. Okay.
Hi, Dr. Saloner.
Yes.
Yeah, my name's Kim Williams. I'm a researcher here in the Value Institute. And I was just having a conversation with one of my colleagues the other day about this increase, and this unfortunate increase in rankings up from number 6 to being second in the nation. I know that we recognize that fentanyl is probably a large contributor to this, but do you have any other thoughts as to what is contributing to this, for the state? And as look on and you show this great order, these rankings, there's definitely a regional trend as well. Yeah. So could you speak more to that about why is maybe fentanyl maybe more prevalent in the area, or are there other reasons as well?
Yeah, it's an important and good question. I think another thing that's going on here, which doesn't immediately pop out in the data, has been what we now think of as the fourth wave of the opioid crisis. So we talk about the first wave as being what started basically in the 1980s, really, with prescription opioids becoming more commonly prescribed. Then around 2010, there was a big shift in the market to heroin. And prescription opioids are still very much a contributor to overdose, but heroin became much more dominant. And then around 2015, 2016, we saw fentanyl enter the market. Now what we're seeing is a crisis really related to polysubstance use. So fentanyl is starting to work its way into the drug supply of cocaine, methamphetamine, And that really has profound implications for who is now at risk of overdose. And in particular, although we think about the overdose crisis as being a crisis that's disproportionately affected white Americans, it's become much more, overdose deaths have been rising much more rapidly in recent years among Black and Latinx populations. And so if you think about that in the context of Delaware, really what you're seeing is fentanyl entering drug supplies for populations that may not have even been thinking about themselves as being people who use opioids, but all of a sudden there is fentanyl. So I think that is one factor to really, think about. We could also talk a little bit about what the COVID pandemic has done to further kind of create a difficult situation. I'm showing you data through 2019. What I can tell you is that the 2020 data are much worse than even this. I'm very sorry and sad to say. So I think we have an incredibly complex crisis right now.
Yeah.
That's also something that we saw in our own data, where we find, in fact, in our hospital data that there is an increase in opioid withdrawal, a really sustained increase since 2018, and mostly related to fentanyl.
Yeah. And I really want to credit Christiana as a hospital system with being a leader in terms of screening for opioid withdrawal in the hospital. You don't know it's there until you start looking for it. And I think Christiana has had a good program of trying to identify patients in opioid withdrawal in the hospital. I think that's another key touch point where there's a real opportunity to find people who may have a problem that they're not presenting with, but it's there. So incarceration, I think of incarceration as, on the one hand, an opportunity, but on the other hand, a lethal exposure. It's an opportunity because it's a chance to help someone, but what we know from many, many studies is that, first of all, opioid use disorder and opioid withdrawal is very common among incarcerated people, and I think that 1/5 as a national number is probably much higher in a state like Delaware. Now, I think the real key thing to know is that when people are incarcerated, they undergo withdrawal if they're not treated. So they stop having the same tolerance to opioids. And that means that if they come out of a carceral setting and go back to using drugs in the way that they were pre-incarceration, their risk of overdosing from that same amount of drugs, even an amount that they may have previously been able to tolerate, is massively higher. And we have this really stunning number that in the weeks after release from prison, people have more than a 100-fold higher risk of dying from overdose than the general population. 2019, the National Academy of Science, Engineering, and Medicine released a report, and I really give them credit for a title that doesn't mince its words. The title is Medications for Opioid Use Disorder Save Lives. And that's really what you need to know. We have 3 medications that are approved by the FDA. They are shown to be safe and efficacious: methadone, buprenorphine, and naltrexone. So methadone being the oldest pharmacotherapy that's been approved in the U.S. It's been available since the 1970s. The challenge with methadone is that it can only be administered through an opioid treatment program, so through just special clinics, not widely available. Buprenorphine can be prescribed by clinicians who have the what's called the X waiver, the special license from the DEA. And buprenorphine is a medication that can be prescribed and taken for outpatients. And then naltrexone, which, to be frank, we have less evidence on its effectiveness compared to buprenorphine and methadone, is what's known as an opioid antagonist. So it's whereas pharmaceutically, methadone and buprenorphine are a form of opioid, but opioids that aren't that don't create the experience of euphoria and are much more normalizing for patients. Naltrexone actually repels opioids from the system, so some patients actually want to have that opioid blocking effect. So we could talk about the different medications. The key thing to know is that in many studies, including clinical trials and observational studies in real-world populations, we see huge reductions in overdose risk when patients have methadone and buprenorphine compared to patients who are treated without medication. Medications improve quality of life, they reduce risk of infectious disease, they reduce criminal activity, and so they are, to me, one of the key elements of giving patients a ticket to a better life. So there really is no scientific debate about the merits of medication treatment. That doesn't mean that there's not a active, let's say, conversation in the treatment community. There's still a lot of people who are resistant to the idea of medication treatments, and there's a lot of stigma against medication treatment. So I don't want to minimize that that conversation, but scientifically, I think that there's clear consensus on the value of medication. Any comments? Also, yeah, go ahead, Kim.
Sorry. I'll
Yeah.
just kind of jump in and say that yes, we've had similar conversations. I think at Christiana, we're definitely big proponents, just as you allude to with the opioid withdrawal treatment program. That's been a way for us to start treating opioid withdrawal with Suboxone. Not the opioid use disorder itself, but per regulations, treating withdrawal, but then to help navigate the patient into community-based, medication-based treatment, hopefully. So definitely, I think Christiana Care has tried to be a proponent of a medication-based treatment.
Yeah, I think that's great. And I think that the other important paradigm in the field has been a move away from highly structured programs toward what I would call a more low threshold model. So providing patients with bridge clinics, providing them with kind of easier on-ramps to treatment, not requiring that they be fully abstinent at the time that they start treatment. There's just a lot of barriers and restrictions that the system puts up that I think, while they can be well-intentioned, are not allowing the life-saving medication to get to the patients as quickly as they can be. So I think a lot of systems are moving toward that low threshold model.
Yeah. Oh, one more point though, as you know, that is another, I think, barrier for naltrexone because it is an opioid agonist, the patient does have to be fully abstinent before they can take naltrexone, and I know the literature shows that is a barrier to initiating treatment for naltrexone, unfortunately. But buprenorphine, that's not required. So.
Yeah, exactly. So what I kind of take away from the literature is that once patients start naltrexone, they can have pretty good outcomes. But getting patients to start is really the tricky thing because a lot of them aren't in a situation where they can be fully withdrawn from treatment, nor is that always sort of the most beneficial thing for the patient. So yeah.
Exactly. Yeah.
This is a 2018 study published in JAMA Psychiatry. I think that it really got a lot of people's attention using statewide data from one of the states that has been a leader in terms of providing all three medications in their state prison, Rhode Island. Rhode Island is kind of a cousin of sorts of Delaware's. It's a geographically small state with a unified detention system, meaning that everybody who is either in the jail or prison population flows through one facility. So they did have the ability to kind of do things in a much more intensive way with their incarcerated population. And what they showed is that after they implemented the statewide medication program in their Department of Corrections, that they were able to see a 61% drop in mortality from overdose. The other number that I think is really spectacular here is that the number needed to treat to prevent a death from overdose was 11. So for every 11 patients that were treated in their DOC on medication, they essentially averted one overdose death. I think that's a really amazing kind of payoff to treatment. So I hope that I've at least convinced you that we have effective medications, that they can be done in a criminal justice context, and that they are life-saving. Now I want to just provide some perspective from the nation and the region on medications for opioid use disorder in jails and prisons. So I think that we are really in an exciting time on this topic. If I look at what has changed in the last 5 years, I'm seeing huge amount of growth in terms of more carceral authorities raising their hands and saying, yes, we will do this. And I think that the pace has been really spectacular, but I would still say that it's not the standard of care for most incarcerated people. So although it's growing in a lot of more progressive states, it's not being done at enough scale for enough people to really have its full public health impact. The other exciting thing has been a lot of consensus statements and endorsements from big national associations, including the National Governors Association, American Correctional Association, which is sort of like the key trade association for correctional authorities, National Commission on Correctional Health Care, the U.S. Substance Abuse and Mental Health Services Administration released some really good guidance on this. So a lot more kind of documents for guiding the field on this than I think there have been. And then another key thing, and this really should not be discounted, has been the threat of litigation. So the ACLU has successfully brought forward lawsuits on behalf of incarcerated people. In full disclosure, I have provided, I've joined amicus briefs in support of this. I think that it is the right thing to do legally. I think it's the right thing to do from a public health perspective. And ACLU has won some big cases in this area. So I think a lot of carceral authorities that may have said, we don't really want to do this, are saying, well, we also don't want to get sued. So I think that this is also spurring a lot of action on this front. And if you look at our region specifically, there's been a lot of momentum in the Mid-Atlantic. I've got to say that I've been really impressed. So MOUD is now broadly adopted in Philadelphia's jail in a very impressive way, across the Pennsylvania Department of Correction, in the New Jersey Department of Correction, in many New Jersey jails. There's a big push underway right now. Great programs in places like Camden County. Washington, D.C., where I live, it's now a pretty comprehensive program. Several jails in Maryland, and this has been something that I've been digging into more, and the state now has a law requiring all the jails to provide all 3 FDA-approved medications for incarcerated people by 2023, and even in West Virginia. So I think all the states are kind of seeing that, we are a high-need area, and this is a high-need population, so let's try to start kind of moving things forward. Any comments? Share some qualitative research that our team is, we haven't published this just yet, but I think it'll come out in a journal relatively soon. We've done some interviews with correctional leaders to learn more about how they implemented their programs. And basically their take on it is that it can be done, but it requires solving a lot of different kinds of problems. So it takes leadership. Here's a quote I really like. So this person says, "We were not asking for permission as much as saying, this is a care need for our patients, and we're moving in this direction, but you, the custodial staff, the warden, have a role to play in this." So the medical team was kind of leading on that one. They also talked about stigma as being a really important impediment to overcome. So the stigma exists in our offender population, it exists in our provider population, meaning among the medical staff, and it exists in the uniformed custody staff and administrators. But this is something that I think is really kind of underplayed. It improves the experience of working in a prison for the correctional staff. So particularly the nurses and the officers, once they saw the benefits of getting rid of these really difficult withdrawal patients and kind of eliminating that problem that they don't have to deal with anymore, they were quick to convert their attitudes. So kind of turning this on its head and saying this is not something that's going to inconvenience you to have to provide this program, it's actually going to make your job easier, I think has been an important selling point in a lot of places. Any observations, comments, thoughts? Okay.
Me again.
Yep.
Sorry, quick question. Have you seen the stigma that we kind of see just broadly about medication for opioid use disorder? Do you see that in the criminal justice community as well among people who work in the system, but also individuals who are incarcerated?
All different kinds of stigma, and they overlap in all kinds of interesting ways. So I could kind of like catalog the different stigmas. There's just sort of the general stigma that exists in the community about, when you use methadone or buprenorphine, you're substituting one drug for another, kind of that old idea. Then there's kind of people's internalized stigma that they have about their own addiction, like I'm a person who has a substance use issue, so I'm a bad person. Um, the idea that incarceration should be a penal kind of punitive experience, so kind of the extent to which a therapeutic approach is really appropriate. In some places, that's been a little bit of a hard sell. And then just the sort of internalized stigma that people have about themselves. A lot of people who are incarcerated, unfortunately, kind of lose a lot of their sense of self. They are subject to a lot of external control. They don't feel like they have as much sort of autonomy in their lives. So all of these things, I think, compound and make it very hard for some people to start treatment, and a lot of people are being counseled by other prisoners, by staff, not to take medication. So these are all issues that are very kind of front and center in how this is happening. I think it's a reason why even when the program's available, a lot of people don't kind of raise their hand and say, I want to be part of this. Great question. This is a figure that my colleague created, and I think it nicely sort of shows the multi-step pathway of an MOUD program in corrections. You have to have some kind of screening, so you have to figure out who are these folks who need this. You have to have a plan to actually dispense the medication, which is non-trivial because these are medications that have a risk of diversion, meaning that patients can be given it and then they can take it in and give it to another person, so they have to be directly observed, and that takes a lot of staff time. Different kinds of participant requirements are sometimes imposed, including counseling or requirements about needing to taper. And then this is the key piece, and this is the part where I really want to talk to you all today, re-entry. So it's not enough to get people started when they're incarcerated. They need to have a way to continue once they've left. So kind of finding their way into care in the community and having a care linkage strategy. I think this is really key. Yeah. So if anyone has any observations or comments about treating people who have been incarcerated, I definitely welcome your comments. I know there's some clinicians on this line too.
Hi, my name is Lori Jabsoni. I am the tobacco treatment specialist here at Christiana, and I obviously have an interest in this with teaming up with kind of what we do, and we find that this is the same type of problem with smoking cessation. People go into prison, they come out, and a lot of times they say, well, I quit for the 6 months that I was in prison, but as soon as I hit the door, I started smoking again. So my question for you is, in terms of reentry, I believe, and please correct me if I'm wrong, that a lot of the inmates, when they leave, they can apply for like state Medicaid. Is the Medicaid system willing to pay for these drugs? And if so, how does the patient get a hold of them?
Such a good question. And this has been an area of, I think, progress in Delaware in the last few years. In Delaware, it used to be, and this was really not out of any kind of malicious intent. It was actually because the software systems were not that good. The state would switch off someone's Medicaid when they were incarcerated, so it would be fully terminated. Now what they do is they put someone in suspension. So it does allow for the Medicaid to be reactivated a little bit faster when they are coming back into the community. I don't know exactly how it's going kind of in a detailed way, and that's something that I've been wanting to check back with the state on. What I can tell you is that kind of a key player in all of this is the Medicaid managed care organizations. So someone who's coming out of the prison system will get their Medicaid card, but they'll also get placed into a specific Medicaid plan, and sort of helping that person to understand what's covered. And I think, in Delaware, all the standard smoking cessation pharmacotherapies are covered by the state in the Medicaid program. So in theory, someone should be able to, start back up on their medication. And same for the opioid use disorder treatment medications. I mean, I think Delaware Medicaid has pretty good coverage, but it's just kind of having that, first of all, having that ability to re-enroll, but also having that care coordination experience. I think that's really key. I'll add one more issue, which is really something that keeps me up at night, and that is continued tobacco use among people who have opioid use disorder, and the extent to which treatment programs oftentimes encourage people to keep using tobacco when they're in opioid addiction treatment. This has been a real battle in the field, is getting more treatment providers to take seriously the fact that people with opioid use disorder smoke at very high rates, and that they can be doing great in their opioid addiction recovery and yet still be kind of setting themselves up for a lot of health risk through their tobacco use. So I kind of trumpet that issue a lot because I think it's very important.
I spent 2.5 hours on a webinar yesterday just about that topic, actually.
Yeah, I think the field is changing. I think we know now that it's not good self-medication to keep smoking, but it's like an old school thing that has to change.
Absolutely.
So I'm excited to share with you all some data from the Delaware Department of Corrections. I'll tell you a little bit about what I did, and maybe if we have time, I can tell you about what we're going to be working on going forward. So 2017 was an important year. It's the first year that Delaware started using buprenorphine as any kind of pharmacotherapy in the DOC. They started with their MAW program, so basically they weren't going to set people up for maintenance treatment, but they would allow people to have buprenorphine as a withdrawal medication. So that was an important step in the door. It didn't sort of provide the comprehensive benefits of medication, but in 2019 the state did implement a more comprehensive program called the MAT program. And that program has mainly focused on providing people with buprenorphine in Delaware DOC. In theory, this MAT program was intended to be launched across all Delaware DOC facilities. I think, as you'll see in a moment, the reality was a little bit different, but this was something that was launched by the DOC medical team in partnership with the medical vendor that they had at that time. And the new medical vendor that's working in the state has been committed to continuing the program. So, happy to take any questions about what this program was or has been. In the study that we did, we really wanted to track participation in this MAT program and look at the characteristics of people who received it, and look at some typical patterns of how people are treated while they're incarcerated. I think this is important because actually we know relatively little about what kind of the standard of care, so to speak, is for medication treatment among incarcerated people. So I'll show you some data that I thought were interesting. So we obtained the full set of admissions for people who are incarcerated. So we have this sort of de-identified data set that has about 100,000 unique admission events. People can be admitted multiple times, and indeed that's a very common thing for people to come into the jail and then leave and then come back and have that kind of cyclical pattern. And we also have all the pharmacy records for the incarcerated period during this time from the company that provides pharmaceuticals to Delaware DOC. They're called CorrectRx. So all told, 102,000 admissions for about 30,000 unique individuals. So you can do the math. You can see that a lot of people came in multiple times. 64,000 of those admissions were to detention, meaning basically to the jail. So they weren't sentenced people. They were pre-trial. And then about 38,000 were people who were sentenced, so they had already, gone through that sentencing process. We know when they came in and when they left. We know their demographics in terms of age, sex, and race, and which facility they were residing in. And then for the pharmacy records, what we were able to look at was the specific NDC code, which identifies a unique kind of pharmaceutical. So we know the product and formulation, including its dosage, how many days were supplied, or at least the quantity supplied, and the drug name. From this, we were tagging buprenorphine, and we also looked at other kinds of prescriptions. We could look at the quantity supplied, but not days supplied. I'll get to that in a second. And we used a different kind of grouper to look at non-buprenorphine prescriptions. I know I'm going over this kind of quickly, so feel free to ask questions. Basically, one thing that we were interested in doing is just knowing how many days patients were treated for and at what dosage. So we had to kind of come up with a methodology for doing that. This is a little wonky, so I won't really go into all of it, but basically we just made some assumptions about once someone started medication, they were likely to probably keep filling medication continuously until they ran out of medication. So we have a kind of a way of counting the number of days. We also can figure out the average daily dosage, so I'll show you that. And we also can look at something that I'm going to call the possession ratio. So if you think about the number of days that you were incarcerated and then the number of days of your incarceration stay that you were treated, that's what we're going to call the possession ratio. So that tells you sort of something about whether patients were sort of more or less continuously treated during their incarceration, which I think is a really actually important thing to look at. So just very kind of basically what I'm going to show you is a comparison between the 800 admission events that included buprenorphine versus the 1,000 admission events that did not include buprenorphine. So that should tell you that buprenorphine was still kind of relatively rarely provided in DOC. And so the first column is the no buprenorphine admissions, and the second column is the buprenorphine involved admissions. I think the main things I want you to know are that patients taking buprenorphine were disproportionately female, so about 30% to 20%. That's perhaps not surprising because the state has generally had a different kind of standard for medication treatment for people who are pregnant. What I found really interesting is that there was a strong skew toward white and away from black for buprenorphine treatment. So only about 20% with buprenorphine were black compared to about 49% without, and 80% white versus 51% white for not buprenorphine. And buprenorphine was more commonly used in detention than in other settings.
So I have a question.
Sure.
Yes. How was the treatment, and maybe that's something that you had already mentioned, which I missed, but were there criteria for administrating the treatment? And had all the population been notified as drug users? The 1,900 patients?
Yeah. So you're getting at, I think, a key question and a limitation of our study, which is that all we could say about these people is something about the pharmaceuticals that they used if they were admitted. What we don't have, but what the state does have, just in a format that's very hard to access, is information on how they screened when they were admitted. So everybody who's admitted, for example, goes through an addiction severity inventory, and they also take the COWS, which is the clinical scale for opioid withdrawal symptoms. So, what I would like to do, and maybe perhaps the more relevant comparison, is patients who met screening criteria but did not get buprenorphine versus those who did.
Right.
And DOC has told me that they think that they underscreen, so the number of individuals that they catch at screening doesn't, they don't think that it fully kind of captures the number of people who are really symptomatic, but I think that would still be a better comparison.
So because the 101,368 patients, you don't know whether they were positive for opioid addiction or not.
That's right. That's right. That's right.
I see.
Yeah, I'm going to say just my guesstimate, my gut is that about 40,000 would meet that criteria, but that's something that I'm trying to work with the state to learn more about. Really good question.
Are there any thoughts on why the individuals that were there for detention versus post-sentencing, any theories on why they accepted it and those that were sentenced didn't?
My sense is that the state was a little bit more limited in the number of days that they were going to start and maintain people on treatment. So detention is a shorter stay. So I think that may be part of it. Also, if you are already on treatment in the community, kind of the state had been a little more willing to maintain you on what your community provider was giving you for the duration of your stay. Whereas kind of if you go into sentence, then I think the kind of assumption is that you're going to be in there for a while and that you're not necessarily going to come back out to the same community provider. But I'm speculating a little bit. I don't have kind of a definitive answer for you.
And were you able to do to see whether it evolves with years, whether there was a change?
Yeah, I'm going to show you that. I'm going to show
okay,
you that.
great.
Thank you for that question. Yeah. So just to tell you about a little more about those 800 admissions that included buprenorphine. So the average daily dose actually is very similar to what we see in community populations. It's around 16 milligrams a day, which I think is, fairly evidence-based. On average, patients had about 18 days of medication per admission. I think the more relevant thing, which I'll show you in a second, is the percent of days that they were treated with. I'm just going to kind of skip past some of this stuff because I don't think it's totally relevant or necessary. This is interesting. So patients who were treated with buprenorphine were much, much more likely to receive other kinds of psychotropic drugs. I mean, part of this is for sure going to be due to the fact that patients who have opioid use disorder have a much higher comorbidity of psychiatric conditions. But this just kind of shows you the magnitude of that. And, an incarcerated population has just very high use of psychotropic medications in general. So anxiolytics, antidepressants, and antipsychotics. As I said, this was a program that was supposed to be, and I'm sorry this is a little bit of a blurry image, but this was a program that was supposed to be implemented across all the facilities in the state kind of in a uniform manner. The state was actually a little surprised to see this figure, but we can say for sure that 2 facilities really led the way. Howard R. Young, which is a level 5 facility in the Wilmington area, and Baylor Women's Correctional, which is also in the Wilmington area. The downstate facility, which I think is SCCC, if I'm not mistaken, or SCI, had much lower use, even though I think that it's a similar-ish population to Howard R. Young. I'm not a Delawarean, but the sense that I have is that things downstate are a little more conservative and kind of the mentality is often a little bit less kind of progressive in some ways. So, speculating because I want to get down there and learn a little bit more, but I think that this was just seen as maybe a more acceptable treatment in the Wilmington area.
Also, I believe, and I'm not specifically positive on this, Baylor and Young have jails. I don't believe that Georgetown, which is downstate Delaware, and Smyrna are necessarily jails. They are where you're sentencing individuals go. Baylor and Young, especially Young, is just jail. You can, you're there for a short period of time. Whereas the downstate, once you're sentenced, they say, okay, this is where we're going to put you. So I'm actually surprised that they were surprised. If they knew that they were giving it more to those who were in there for detention prior to sentencing, those would be the places, the places with the jails would be the places that you would see the rise.
Yeah, that makes sense. I think the thing we could do, which would be a little more apples to apples, is compare the sentenced at Howard R. Young to the sentenced at Georgetown and see kind of within those groups what the contrast is. I still would be willing to guess that you're going to see more use among the sentenced, but maybe it's because they got it more readily when they were in detention at Howard R. Young. So something to look into for sure. But I appreciate that point. So here's that question about the time trend. So what we see as the MAT program kind of eclipses the MAW program is that the duration of buprenorphine, the number of days that patients are treated, increases over time. And not surprisingly, that possession ratio, which is the share of days that the patient, the share of the days in the stay that have medication, also increases from like around 40% in 2017 up to about 80+% in 2020, so much higher possession ratio. And interestingly, although detention had a higher take-up in general, the share of treated days was actually lower in detention, and what I want to look a little bit more into is whether that's because there's a delay in terms of starting patients. So they kind of come there, they're in withdrawal, and it takes a while to get them started, which I think is possible, or whether it's sort of on the back end of the stay, and so they kind of know they're leaving detention, so they fully taper and withdraw, and that may not be such a great treatment protocol either, because then basically they're medication free at exactly the time in their stay when it's most important for them to have medication on board as they re-enter the community. And other, in case you're wondering, is a small number of individuals that are in community corrections, not really kind of a large share of this sample. I probably should have taken it out. I'm just going to summarize what I think we've learned from this study. So in Delaware, we see this important increase happening around 2019-2020 in take-up of buprenorphine, particularly at Baylor and Howard R. Young. Increase in the duration of treatment, which I think is really important. We do see that the treated population skews heavily white, female, and people who receive other meds, especially psych meds. And I think in somewhat good news, the average dose of medication is comparable with what you would find in the community. So those are sort of my take-home points. What I didn't include in my slide deck today, but what I can talk a little bit about is sort of the follow-on plan. It's a very descriptive study that you just saw. I am in the process of working with DOC and with the state Medicaid agency to, and I should say with colleagues at University of Delaware to create a data linkage between Medicaid records and DOC records so that we can track what happens to people who are incarcerated in Delaware DOC once they come into the community. So we'd like to see, for example, for these 800 admissions, how many of these patients continued on medication after they left DOC custody, kind of what was the typical lag between that time of release and the time of starting up medications, how many of these folks non-fatally overdosed among the 800 and among the kind of the larger 100 and 1,000. A lot of questions are I think answerable, and I also would argue that having these kinds of data can help the state understand from a fiscal perspective, what is the cost of doing this and what are the benefits. It would be wonderful, although I don't know if this is going to turn out to be true, if the program actually saved the state money. You could imagine that it would save the state money if paying for medication when someone is incarcerated is cheaper than treating an overdose post-release. I think even if it costs more money, it's probably worth doing because just improving people's quality of life. when the scope of improvement is so great. So these are the kinds of things that I want to look at. Comments, thoughts?
This is very exciting. I have a couple of questions. Do you know whether there are addiction treatment program, the formal addiction treatment program we have in the state, who have a contract with the Department of Justice to assist individuals who leave the prison so that they can, or the jail, so that they can continue their treatment, their MAT?
Yeah, so it's been a little bit of a patchwork. There's really a few state agencies that are relevant here. One is DSAM, so the Department of Substance Abuse and Mental Health, DSAM. And DSAM does assist with some of that care navigation. There's actually a platform in Delaware, which I think you guys may know about, called Open Beds, which in theory is a care navigation tool. And Open Beds is working with DOC to help place DOC clients in community treatment. Just because you try to place someone from DOC in a community treatment program doesn't mean that the referral is always accepted. There's a good number of denials. So I think that's really an important policy area. There's carrots and sticks here. You could provide more incentives to help providers treat these patients, and I think that's good. But there's also sticks. You could kind of do a little bit more to have a hard edge and say, you know what, this is really a population that you, the providers in the state, need to start treating. Because it can be a complex population with a lot of needs. So there's some hesitance about taking on these patients. But if they don't have a place to go, the outcome can be very bad. I don't know, did that answer your question?
Yes. I thought that there would be, a formal relationship with DOC and some of the treatment programs that would, as soon as someone would be discharged, they would take this person, in charge basically, and make sure that they have their medicine, their medication.
Yeah, so I don't think it's as good as you hope it is. There's elements of that kind of strategy, but it's not kind of as fully worked out as one would like. And a lot of people leaving DOC custody are not getting prompt connection to care.
Well, I hope this is. I'm sorry, go ahead.
Do you by chance have any of the data? And again, I know that you said you were trying to work on to kind of get the systems to match up a little bit better. Do you know if any of these patients, any of the inmates, upon release, are they leaving with prescriptions for said medicine and not getting them filled, or is it just, on the other side of the gate is you? Go find a provider, go find your prescriptions, whether it be as easy as blood pressure medicine. I mean, are they leaving with anything, or is it just, hey, go do, you're on the other side of the gate, you're not our problem?
Yeah, I can't really speak to whether their protocol right now is to write a prescription like, hey, you're on your way out, go to Walgreens and pick up this prescription. I think the problem is who's going to pay for it. There is an important option in federal policy that I hope will be coming to Delaware someday soon. The U.S. Department of Health and Human Services needs to put out some more guidance on it, but the state can apply for a waiver to allow Medicaid to start kicking in and paying for some of that care during that 30 days of release. So I think that could be kind of, the problem is always who's going to pay for it, and if Medicaid hasn't been turned on, then DSAM is going to have to basically eat the cost of it, and DSAM does do that to some extent, but you really want to have a better payment model. I think that's a consideration. What I will say is that in Philadelphia, and this is something that kind of blew my mind, people leaving the Philadelphia, it's called the prison, it's really the jail, leave with a blister pack of buprenorphine. So they actually just hand them medication on their way out the door and give it to them, along with some naloxone, which I think is a really underutilized strategy. I'd like to see that kind of thing happening more and more, because really, like, if you don't get someone their medicine in the day or two after they leave, they're going to start looking for options to treat their withdrawal.
And do we have results from the Philadelphia experiment, whether people to make sure that the drugs are not diverted, or and that people really take their medications?
Yeah, we don't know how much of that medication is actually ending up in the patient. I got to be honest with you. I think that there's a reasonable trade-off to be made for allowing a little bit of medication diversion, or just tolerating some amount of it, in the spirit of kind of prioritizing medication that the patient is likely to take. So
Right.
this is always the concern. But I think, doing the risk-benefit calculation, I tend to think that it's better to just get the medicine out there. Patients very rarely overdose on buprenorphine, especially if they have a history of opioid use. They're much more likely to overdose on fentanyl or heroin.
Right.
But yeah, it's still something to study.
And the rates of fatal opioid overdose after incarceration are exponentially higher. Like, that's like a high risk period, correct?
That's where that 100-fold statistic comes from that I was describing earlier. Yeah. I think I have 4 minutes left. I want to leave on time, so I don't know if you can hear my kids. They seem excited. Yeah, so let me just conclude. Carpe Diem, seize this day. I think that we are in a moment of incredible opportunity. I hope that my presentation left you feeling more excited than despairing. I think there's so much good that can be done here, and I think that there is a huge role for the community providers. So I've moved from saying that MOUD should not just be available in jail and prison. It should be the standard of care, meaning that every patient who qualifies for it should be sort of assertively offered it. Not everybody has to take it. I'm not, saying that 100% of people with opioid use disorder need to take it, but I think that it should be much more kind of front and center as a treatment that is seen as legitimate and valuable. It does require a lot more screening, and requires taking on a culture where this has been stigmatized. And as I said, I think it requires a lot more robust linkages with post-release care. So you community clinicians, you have a huge role to play. These could be your patients, and you could make their life so great. So thank you for your time today, and thanks for having me. It's been really fun to have this conversation.
Thank you so much. This was wonderful. Thank you.
I might have time for 1 or 2 questions. I don't know.
Any other questions? Other questions for Dr. Saloner?
Okay. Well, I put my email up. I'm happy for anyone to reach out to me, and just really, I love Delaware. I think that there's so
I
many
think
great
we'll keep
things.
in touch.
Yeah.
We
All right. Well,
we
thanks.
love data, so I think we can, I'm sure we'll find ways of collaborating. That'd be
Good. I
great.
love that. Yeah. Okay. Thank you, everyone.
Great. Thank you.
Thank you. Great presentation.
Thanks.